outside, I'm gonna go over the first part of respiratory emergencies. So that's one of the most common conditions that we get called out for, one of those common dispatches, along with chest pain and some other associated symptoms. We have some of the most common diseases being asthma and COPD. They're some of the leading cause of death and disability. Patient be homebound, patient be bedbound because they can't walk due to just not being able to have any oxygenation. We have 16 million Americans with the COPD and 25 million with asthma. Pneumonia is one of the most common, fatal diseases in your developing countries, but it is a problem here. We see a lot of times patients that are bedbound, nursing home, can't clear their secretions, constantly laying down. They can have genetic factors that predispose them to asthma or COPD, or it could be the fact that they smoke, poor habits, exposure to chemicals if they work in plants with a lot of smoke, any kind of external factor like that. Your A&P, your pulmonary anatomy typically looks like an upside down tree. The trachea will be the trunk, the alveoli will be the leaves at the end of these branches. Your bronchioles will be your actual smaller branches that break off the trachea. Your trachea starts at the tracheobronchial tree from the mouth and the nose where you inhale, and you have air that's inhaled through the nose, go down through the upper airway down to the trachea. It extends down to the bronchi where it breaks off at the carina into the left and right side into the lungs. And remember, your right lung has 3 lobes, so there might be a little bit more surface area on the right side. Your main stem bronchi branch into the lobes of the lungs and then into these different subsegmental bronchi, so your tertiary, your subsegment, and your bronchioles. And then you have some space in the bottom of your chest called dead space, where there's no air movement whatsoever. Patients that have significant lung disease, you'll see more dead space as time goes on and their disease progresses. You also have your gas exchange here, also in the bronchioles. It's not just the alveoli, but it is your bronchioles too. They lack cilia, so they aren't able to really protect you from microbes or anything that's coming in. But they do participate in a significant amount of O2 exchange, where you have your deoxygenated blood with the blue, where your CO2 is going out for you to exhale. Your red is your oxygenated blood that you're pulling in from the heart. Remember, we know our blood flow through the heart. So you've got your pulmonary arteries and veins taking in oxygenated blood and out CO2 in the blood. So you have this occurring on the bronchiole down all the way to the alveoli. So you have no protective mucus in that tracheobronchial tree and those bronchioles. You're not shielded by any smooth muscle or rigid structure. The smooth muscle around the airway, you can have bronchoconstriction, which is where you'll actually hear it, most of the time wheezing in the upper airway. Bronchodilator medicines such as your albuterol, your ipratropium in combination with your albuterol, things like that are what we give to kind of dilate those airways to open them back up from that bronchoconstriction. Branches 16 to 24 are your terminal airways that lead to the alveoli, so that entire space is nothing but capillaries for gas exchange. This is where most of our gas exchange does occur, but a significant amount still occurs in the bronchioles. So you have a mediastinum in the anatomy also, which is the space in the middle of the chest, which is your heart, your major blood vessels, the large airways, and most of your upper organs, so your lungs are included in that as well, and the thymus when you outgrow it. Usually you outgrow it in your adolescence. Pulmonary blood flow from your heart to your lungs, we notice that from learning the heart anatomy, the pulmonary artery. They branch into smaller vessels and all the way down to those alveoli, to those capillaries. More gas exchange occurs between the lung bases and the circulatory system. Our capillaries are super narrow and small to allow for the diffusion of gases across. And then you start talking about diseases like polycythemia, which are issues with the accumulation of more red blood cells than normal, usually caused by COPD. And then cor pulmonale is your right-sided heart failure that comes from issues with the pulmonary system. So your perfusion, it's the end-all be-all of circulatory component and the respiratory component is ultimately perfusion. We need oxygenation to our tissues in order for us to be able to do anything and survive. That includes our brain, everything all the way down to the cellular level. blood must keep going through those vessels in order for us to keep getting oxygen throughout the body. Something like a large embolus can block your blood flow and cause issues with respiratory distress, chest pain, anything like that that can prevent us from getting oxygenation, and it is a medical emergency. Remember, that's one of the H's and T's of cardiac arrest is a thrombus, a pulmonary thrombus. So respiratory control, you have cardiovascular regulation where your lungs are really closely linked to your heart, they really work hand in hand. Issues with the heart do have pulmonary consequences. Right-sided heart failure, you have lower pitting edema, you have some of those core pulmonary issues, and then you have left-sided heart failure, you obviously have pulmonary edema when fluid starts backing up into the lungs. So your left-sided heart failure progresses faster than right-sided heart failure, but they can have both. They can have one that leads to the other, typically they start right-sided heart failure that leads to left-sided heart failure. You have mild hypoxia, which you can see sometimes it may just increase their respiratory rate, or they may be slightly agitated. Severe hypoxia, you start seeing that decompensation of bradycardia, they may have altered level of consciousness, things like that. And uncorrected hypoxia can obviously trigger lethal arrhythmia. Hypoxia is another agent of cardiac arrest. Heart failure can be caused by fluid imbalances, your right-sided heart pumping problem, and a left-sided heart pump problem. Heart failure ultimately is a pump problem that leads to the pulmonary problem. So your muscular control, your body takes in air passively through the nose, and then it actually, like your diaphragm, the muscle actually pulls the chest cavity open to allow for more air to go into the space. So it's not just an in and out thing. It's passively done, and that's why we can breathe without knowing, is we take air in, your diaphragm goes down, and it actually pulls the air like a vacuum into the chest cavity, which is what that diagram is showing. Your air goes through your nose and your mouth over the turbinates. They make sure your air is humidified and cleans the air, and then it goes down to the epiglottis and glottis and into that chest cavity. Your thorax is an airtight box with the diaphragm at the bottom and the trachea at the top. The diaphragm flattens, and then you have this negative pressure space in here, which is why it sucks that air in like a vacuum. Minute ventilation is exactly what it says. It's how much air is moved in and out in 1 minute. It can be increased by taking a deep breath or by breathing faster. Any kind of traumatic opening in the thorax will cause air to go into the space, and it can eventually lead to a collapsed lung, putting pressure on the heart because that increased pressure in your chest. And that's what we term as a sucking chest wound, which I think basics can do it too, where you put a chest seal on a sucking chest wound to keep air from going in and out. Some people have chest seals, some can make their own. So your renal status plays an important part too, because it helps you regulate fluid, it help with acid-base balance, especially with your dialysis patients that have significant amounts of problems with electrolytes. And then your blood pressure. Are they having hypertension? Are they moving less fluid? What's going on with their blood pressure too? You have to factor in the pulmonary mechanics and your oxygen delivery to those tissues. So hypoventilation, carbon dioxide accumulates in the blood when the lungs fail, combines with water to form bicarbonate ions and hydrogen, which makes your carbonic acid, which is where they get acidotic from not breathing off enough CO2. They're retaining CO2, which you see a lot in your COPD and your CHF patients. That impaired ventilation can be from anything, like that chart says. It can be from trauma, it can be from disease, it can be from obstruction, it can be from airway edema. Anything, or do they have ALS? Are they slowly having nerve damage attacking them all the way up their body? Do they have ALS? That's another thing to consider. It might not just be a pulmonary issue. Is it a neuromuscular issue? Do they have some other type of disease that is causing this? Do they have a foreign body obstruction? Your carbon dioxide level and your pH run hand in hand. I know some of us talk about acid-base balance. Patients can have respiratory acidosis or alkalosis. So that acidosis is typically where they're not breathing off enough CO2. They're retaining all the CO2 because they can't get it out. COPDers can breathe air in, they can't breathe air out. They're stuck with that CO2, which is where their CO2 rises and where they have that shortness of breath. And then that's where you get the respiratory acidosis. The alkalosis is where they're breathing off too much CO2 and their CO2 is typically low. and you'll see that on end-tidal CO2. High end-tidal CO2 is indicative of acidosis, your low CO2 is indicative of alkalosis. So ultimately, it will lead to respiratory risk later on, followed by cardiac risk. So some things that can impair your lung function is atelectasis, which is the collapse, partial or total of a lung. Pneumonia, your infection of a pneumonia. Pulmonary edema, full of fluid, can't move air through the capillaries. Asthma, restrictive airway disease, where it's slowly swelling in the airway, or the airway narrows and you can't get air through the airway. Or COPD, where it retains CO2 and can't move air in and out. So you have conditions that can impair your mechanism of breathing, like the flail chest, where you have multiple rib fractures in multiple different places, causing some seesaw movement of the chest. Diaphragmatic rupture, does the diaphragm rupture from trauma, from steering wheel or seatbelt hitting them right here if they get in a car wreck. Severe retraction, as you see, it's a lot of kids, especially babies, who can't compensate very well. Are they pulling so hard with their muscles because they can't breathe? Air or blood-filled abdomen, the more it fills up, the more it goes up and impairs breathing. Your diaphragm can't expand further down if you have blood in your abdomen. Abdominal or chest binding, any pressure on there can prevent expansion up and down. Obesity, hyperventilation syndrome, do they have so much mass that their lungs literally can't expand? You see this a lot in your very much larger patients, where they have so much extra tissue they can't expand. Conditions that impair neuromuscular apparatus, head trauma. Our brain literally controls our breathing center in our medulla and the pons in the back of our skull. They have any kind of spinal injury. They can have issues breathing or not breathing at all. Spinal cord injury. C4 breathing underwater was what I was always taught. A fractured C4 typically results in death because it impairs your breathing mechanism. Guillain-Barré is another neuromuscular disease that attacks where your own body attacks its nerve cells, so it starts destroying the nerves that are also responsible for your breathing, because you have that phrenic nerve that goes to the diaphragm that's responsible for breathing. Your ALS, or Lou Gehrig's disease, that slowly paralyzes you from wherever the point of origin is up into the whole body until it leads to death. Stephen Hawking, who's a famous guy that had ALS. So you know, he couldn't talk, he was in a wheelchair, and he couldn't move at all pretty much. He's pretty much isolated to one position. Botulism is a poisoning that comes from a certain type of colloquial bacteria that is seen typically with improperly canned food. So stuff at home that you may can improperly canned meat, things like that is where you see botulism, and it's from a bacteria. So it's things that can decrease your respiratory drive and intoxication. So just because a patient is intoxicated doesn't mean they may not be short of breath or have issues with the pulmonary system. But remember, that's a double-edged sword. If they have a pulmonary problem and they're intoxicated, it decreases your drive and your inhibition to say, okay, I need to take a breath. I haven't breathed enough. I need to take another breath. Head injury, again, head injury, you got bleeding on the brain, you put pressure on the brain can't do what it needs to do to tell you to breathe or not to breathe. Hypoxic drive is something seen typically in patients that have long-term CO2 retaining. Your body and my body normally would say, okay, my CO2 level is going up, I need to take another breath. Or for patients like COPDers that retain CO2 all the time, their body switches and says, oh, let me use oxygen instead of CO2 because I always have CO2. So now my oxygen level goes up because I put them on oxygen. My body says, oh, well, I've got plenty of oxygen. There's no stimulus to breathe, so they stop breathing. But that's with severe long-term use of high flow oxygen. And then, of course, asphyxia, whether they're choking, foreign body obstruction, or even if it's traumatic asphyxia. Hyperventilation. People breathe more than they need to, either from increasing their rate or their depth. They release more carbon dioxide than normal, which results in that alkalosis, where you see that low end-tidal reading. Can be panic or just hyperventilation syndrome. That's where your respiratory alkalosis comes in. It causes numbness in the hands, feet, and mouth, what leads to carpopedal spasm or syndrome. Patients breathing carbon dioxide is dangerous. What they used to tell you, breathe in and out of a paper bag, that's extremely dangerous and cause them to pass out. Patients will quickly exhaust their oxygen, and it may be sometimes hyperventilation may be the body's attempt to fix acidosis. Seen in Kussmaul respirations, those are seen in TKA patients. Patient sugars 600, they're unresponsive, they may be breathing faster to breathe off some of that CO2 from that acidosis because their sugar is so high. Sepsis, and then shock reports. If you've ever had to, you could do to treat these hyperventilation syndromes, you could sedate in an extreme measure. Most of the time you can calm your patient, talk the patient through it, and get them to just calm down on their own, to where they can just take some deep breaths, and eventually they'll go back to normal. So your patient assessment, make sure you do a thorough assessment. Respiratory illnesses are life threats. Remember, airway, breathing, and circulation in most medical patients. It's more than listening to the patient's lungs, it's talking to the patient, what medical history do they have, forming a good general impression when you walk in the house. Is the patient tripod? Is the patient sweating? Is the patient breathing 50 times a minute just from you looking at them? You need to be able to look as soon as you go in the door and see patients in severe respiratory distress. Or as you're going on through your assessment, okay, when did this start? Did the chest pain start first? Did the shortness of breath start first? What started first? What medical problems do you have? Have you taken anything for your medical problems today? So if you have COPD, have you hit your inhaler before I came here? How many times have you had to use your inhaler today? Have you ever been intubated because of your COPD or your asthma? If they say yes, you can already anticipate that the patient's gonna do a rapid downline if they do decompensate. Make sure you use standard precautions. Always remember with respiratory, you may need more gloves, you may need a mask. If they have TB, we might not know. They may tell you, I have TB, but during COVID, we all know they created that nice new code, Signal 36, to tell you, hey, they got COVID. Or ours was enhanced PPE, which means they're COVID positive. Make sure you wear your proper PPE in the house. Evaluate for scene safety for diminished oxygen concentrations, or you at high altitudes, anything like that. Carbon monoxide, colorless, odorless gas that you will not know is in there. So that could be a patient that is in a garage, has the garage closed, trying to do a suicide attempt, and they're rolling their window down and have the car crank up in the garage. All that is carbon monoxide. And that's what ultimately causes that death, is carbon monoxide. So you gotta be careful walking in because you won't smell it, see it, or anything. Irritant gases, anything like that can come from if you're on a scene with a crashed 18-wheeler or they carrying an irritant gas in the back of the tanker, which is why we have those placards on the side for you to learn. Highly contagious respiratory illnesses, RSV, TB, anything upper airway respiratory infection, you see a lot with your kids too. Usually if one kid in the house has it, it comes from another kid in the house. Or parents. You're seeing signs of respiratory diseases can impair ventilation, diffusion, perfusion, or all three. Your rapid onset dyspnea can be a bronchospasm, anaphylaxis, your PE, or your pneumothorax. So paroxysmal nocturnal dyspnea is that middle of the night sudden respiratory distress. They wake up coughing, can't breathe, and it just hits them all of a sudden. It could be a sign of left-sided heart failure. Sometimes the ability to move air back and forth can be hindered by things like that limit diaphragm movement, restrict chest wall movement, or disrupt the integrity of the thoracic cage. So disrupting the integrity would be, do they have multiple fractures? Do they have a stab wound to the chest? Do they have a stab wound around here to the side of the chest? I mean, all of those things are important when you're looking at assessing your patient. Always maintain an open airway and make sure you form that good general impression we talked about. The body type may be associated with their condition. So your emphysema, those patients are typically really small and frail, have that barrel chest, that pursed lip breathing, and you'll see them when you walk in, and they're trying their best just to get the CO2 out. Tripod, sweating, you'll see it when you walk in the door. Some of them may have even a reddish tint to them from that polycythemia. They may have like a reddish tint. Your chronic bronchitis, that's your patient that may be more sedentary. You may walk in, this patient in a recliner, has a urinal right by there, has 17 different meds and 3 inhalers on the counter that they took before you got there, but they're more sedentary typically. Always assess their oxygen demand and their worker breathing. Are they labored breathing? Is it normal? Is it shallow? Observe their condition during exertion. Do they get more short of breath when they walk? Do they get more short of breath? Obviously, when they lay flat. Most true respiratory patients won't let you lay flat. Tachycardia, diaphoresis, and pallor. You look for increased worth of breathing, anxiety, and hypoxia. Remember something, if your patient is hypoxic, they will be anxious. Anxiety makes it worse. They are scared because they cannot breathe. If somebody held a cloth over your face and you couldn't breathe, you're gonna be anxious. You can't breathe, you're scared. So remember that when you're assessing these patients, to try and even, if you're trying to put O2 on them, whatever, coach them through the whole process from start to finish, because they are anxious and they are scared. Just remember that. Note your position and degree of distress. Are a tripod. Tripod allows for them to go forward, their scapula rotate backwards, and it allows for somewhat more air movement in and out, which is why they prefer a tripod position. If they let you lay them flat, they're tired. They're not gonna fight anymore, they're tired. When they let you lay them flat, they're decompensating, and you need to be prepared for this to probably lead to an advanced airway, or some type of quick airway maneuver for this patient. Head bobbing, you see that a lot in the ones that are tired, sweaty, they've been short of breath for a while, or even kids, that head start, they're trying their best to find a way to get air. All of these are showing signs of decompensation. You need to be ready for these patients. Breathing alterations can be in the conducting airways, the alveoli, the muscles and nerves involved in breathing, or the structure of the thorax. Increased worker breathing is those accessory muscles. They get dangerous of tiring out. When you've been breathing like that for 20 minutes, because it took me 20 minutes to get there from wherever I was at, they're gonna be tired. They've worked that hard for that long. Their body's tired and their muscles are tired. That wastes energy, more oxygen, and now they're tired. Infants and small children are prone to have that collapsing in the sternum, like in that picture, from them breathing so hard and using those muscles to breathe. You'll see abdominal or retractions of the accessory muscles. Profound pressure in that chest changes, causes those peripheral pulses to weaken or disappear. Remember, the more pressure you put on that heart on one side, just like with a pregnant patient, the more pressure you put on one side of the heart, you can have problems with their blood pressure. Put the pressure on being tegula, the more pressure in that chest, they may lose the peripheral pulse, reducing their cardiac output. These are all the types of signs of works of breathing that you need to look for. Nasal flaring in a child is a medical emergency. If you see a child with nasal flaring, they are already tired. Soft tissue retractions, are they pulling here because they can't breathe? That's that tracheal tugging where they can't breathe. Are they grunting? An adult that's grunting is tired. A child that is grunting is tired. You need to act fast for these patients that have been short of breath for a long period of time. That pursed lip breathing with your COPD, your emphysema, trying to push that air out, trying to get it out. Paradoxical respiratory movement is where they're moving in opposite sides. That could be from trauma, or they've got a significant pushing out of that epigastrum. Do they have an altered rate or depth? So are they only breathing 8 times a minute, or are they breathing 50 times a minute? Are they breathing shallow? Are they breathing normal? Or are they deep breathing? Are they labored breathing? Are they not breathing at all? Patients, you need to monitor without your patient seeing. If you tell them, hey, look, see, I'm gonna count your respiratory rate, they're gonna try and do it more so you can see it. You need to watch and look while they don't know you're looking, so you can see how it naturally is. Monitor your trends and their inspiratory to expiratory ratio. Are they taking longer to exhale? Are they taking longer to inhale? Abnormal breath sounds, you wanna make sure you listen systematically to all the lobes, top, back, and on that right one, you need to listen on the side. Some conditions are gravity dependent or diffuse throughout the lungs, so fluid. If I'm sitting up, my fluid's gonna follow gravity instead of the bottom, right? So when I'm laying down, fluid's gonna spread all the way out across the lung, which is another reason why they won't let you lay flat. Abnormal breath sounds, you can hear them in any of those large airways. So these are some of your normal breath sounds that you would hear. Your inspiratory and expiratory sounds, your bronchial, your bronchiovesicular, or your vesiculars. And it also depends on how much tissue is between your stethoscope and the patient's lung. So abnormal breath sounds. Some conditions can cause abnormal breath sounds to be heard in the wrong place. Sounds move better through fluid than through air. And like I said, the quality depends on how much tissue is between your structures and your stethoscope. Adventitious slug sounds are those abnormal extra sounds on top of other breath sounds. So you can have wheezing, crackles, bronchi, rails. These are the ones you typically listen for in the back of the truck to determine which lung condition they may have, or they may have more than one. You hear wheezing, that's typically an upper airway problem. That's narrowing up the upper airway. When you got crackles or sometimes bronchi, sometimes crackles is fluid, sometimes bronchi is typically your infection or your pneumonia, or they've got some type of respiratory infection. And then you hear rails, that's typically fluid. Audible sounds can be your stridor, your grunting, or your death rattle. Stridor is a very high-pitched, almost like a seal barking sound. It's very high-pitched, and it is an upper airway problem. That can come from upper airway obstruction, epiglottitis, whooping cough, things that you would see in kids, croup. Grunting, like we talked about, are they audibly grunting? And that death rattle is a very distinct sound if you ever hear it. Just a very distinct sound. And then ominous is no sounds. Silent chest is deadly chest. They're not moving air, they're not moving air adequately. Or they're not moving anything at all. Are the airways so tight that you can't hear air moving back and forth? Noisy breathing, you got snoring, gurgling, and stridor. So your snoring you see with your patient that may be unresponsive, the tongue's occluding the airway. Gurgling, they're full of secretions. Do they have vomitus in their airway? Do they have blood in their airway? Stridor, again, is that high-pitched upper airway problem. Quiet breathing, the hyperventilation, shock, or acidosis. Are they just sitting there with their mouth gaped open and you can't really hear them breathing because they're taking such shallow breaths? Sputum. Sputum can tell you a lot about your lungs, about the color. Is it blood tinged? Is it pus? Is it yellow? Is there blood in it? Or is it that frothy pink? They all are usually indicative of certain processes like heart failure. Your blood streaks typically like a cancer, tuberculosis, or trauma from coughing. Abnormal breathing patterns, they may be indicative that they have a neurological problem. It may not just be a respiratory problem, it may be a neurological issue. Brain trauma can be a cause, or any disturbance like a stroke, anything like that with the brain. They depress those respiratory controls in the medulla, or they damage or deprive the blood flow. Most respiratory centers are or in around the brain stem right here with the pons in the medulla. They tell you when to breathe, how much to breathe. It controls your heart rate, it controls all of those things. So if you have somebody who may have been struck here, you may see issues with their respiratory center and the respiratory drive. Issues with a brain bleed, is it pushing their brain stem from all that blood and pressure in there? Is it pushing the brain stem further down? So you need to be looking for these types of issues with respiratory rate. You need to consider, oh, hey, they have this kind of breathing, maybe they do have a neurological insult. They may be unresponsive and can't tell you what happened to them. Apnoistic, Biot, and Shane Stokes. Your apnoistic is usually the no pattern. Shane Stokes, they do a like slow inhale, long exhale, and a period of apnea. So there's, see that top one is they do a short inhale, long exhale, and then the apnea. The Shane Stokes, or the central hyperventilation is kind of everywhere. The apnoistic is scattered. They may take a deep breath, a shallow breath, a deep breath, and then have some periods of apnea. Then of course the bottom's your agonal, where they're barely taking any breaths. That's kind of like your Govey breathing, what we call Govey breathing. And those are all the different types of respirations they can have. Seeing those Kussmaul's up there is typically your diabetic acidosis. The common one is obviously the eupnea, which is the normal breathing. Bradypnea is just where they're breathing slow. Ataxic is typically irregular respirations that can be from your brainstem herniating. Injury to spinal cord and polio, we know polio was a disease that we tried to eradicate with vaccines. It caused paralysis all the way up to and including your lungs. You just seen the guy that was in the last iron lung just died here probably within the last year. He had the paralysis of the diaphragm in the lungs, so he's in the iron lung that was actually breathing for him from polio. A lot of our grandparents were alive for polio. May disable respiratory muscles, tidal volume could be shallow, and patients really need assisted ventilation if they have some spinal cord injuries. Circulation assessment, you wanna look at skin color. Do they have cyanosis? Are they sweaty? Are they diaphoretic? Are they clammy? Assess their mucous membranes. Not every person's skin color will be easy for you to assess. Not every person's skin color may be easy for you to assess, so you may need to look at their mucous membranes. Pull their lip down and look in their mouth. Is this right here pale white? If it's pale, that's a sign that they are severely cyanotic and dehydrated. So there's pale mucous membranes, you look in the mouth, some of the eyelid, any of that that's not the right color, because some patients you can't tell if they're pale or not. So cyanosis can be from issues with hemoglobin, typically when they get down to about 5. Most of our patients typically 12 to 14, below 12 is your anemia. Above is where they have so much hemoglobin they need to get blood transfusion, they need to donate blood. Dark brown skin can be from high levels of methemoglobin, most apparent in venous blood. You have pallor, which is blood flow reduction to the small vessels. You can have shock, hypoxia, lack of sun, anemia, catecholamine response. You also want to check for that dehydration. Like I said, they have dry, cracked lips. They have a furrowed tongue, which has all those lines in their tongue. Is their tongue pale? Dry, sunken eyes. They have those dark around their eyes. They just look like they feel terrible. For our transport decisions, if they have any kind of respiratory problem, we really want to try to transport them to the closest hospital. If they have any kind of renal failure associated with it, also, you may need to consider a place that has emergent dialysis also. Some places will only do emergent dialysis. You can consider taking them where they want to go, their preferred place, if distance allows, if they have been there before and they have access to the records, and if you think that they're stable enough to go that far. When you're taking a history from a patient, have patients explain how they're feeling in their own words. Don't give them yes or no questions, give them open-end questions that call for more explanation. Common complaints, cough, changing the color of their sputum, fever, wheezing, dipsy, and chest pain. Some of those go hand in hand together. Patients may have a known problem. Do they have asthma with fever? Do they have not delivered medication? Do they have a travel-related problem? Remember, you can pick up respiratory illnesses when you are traveling to and from other countries. Well, they ain't gonna have to. Seasonal conditions. Do they only get worse a certain time of year? Dyspnea triggers. Are they around smoke? Patients that have asthma or COPD can tell you typically what triggers their asthma or COPD. Am I around somebody that was smoking and now I can't breathe? Some people it's that, some people it's perfumes, it's chemicals, anything with a strong smell. Non-compliance with therapy. Are they taking their medicine like they're supposed to? If they're not, sometimes it will lead to exacerbation. And patients need to understand that non-compliance can lead to these problems. So you might want to encourage them to regularly take their medicine to prevent issues with exacerbation. Your sample, we know our signs and symptoms, allergies, medications. Do they have pertinent medical history? The last time they had anything to eat, and events leading to the onset of complaint. The reason we also want to look at last oral intake for a patient with respiratory distress, if you have to consider intubating that patient, you may want to know the risk are they going to vomit when you go to intubate them. And you should always have suction ready when you go to anyone's airway. Secondary assessment. Neurological assessment. Do they have altered level of consciousness? Are they alert? Only responsive to verbal, only responsive to painful. Lungs not functioning correctly, the oxygen may not be delivered, CO2 may not be removed. Your neck exam, JDD, one of the first things you look at when you start your head to toe, you get to your neck, you're looking for JVD, that's a sign of increased work of breathing too. Usually the veins are encorded with blood, they measure the pressure in the right atrium, it can be cardiac tamponade from a pneumo, heart failure, COPD. You can also assess it, through the hepatojugular reflex. Your patient sent in a semi-phallic position, you place pressure, and their jugular veins distend, that's also a sign of JVD. When you look at their neck, do they have any tracheal deviation? Do you see it going to one side or another? That's a sign of a tension pneumothorax, or late sign of a pneumothorax too. Behind their sternum, the whole trachea will actually deviate, not just the part you can see, the entire trachea will deviate over also. You can palpate it also at that substernal notch just above the manubrium up there. You can also see it on an x-ray. Your chest and abdominal exam, pressing on the liver when the patient's in respiratory distress and in that semi-phallic position will cause those jugular veins to bulge, that's hepatojugular reflex. Feel for vibrations in the chest as they breathe. Any chest or abdominal trauma can cause respiratory distress. Look at their extremities. Do they have edema, like this pitting edema right here from CHF, right side of heart failure, or a combination of right and left? Is this normal for them? Do they have lymphedema? Cyanosis, do they have any kind of cyanosis to an extremity, one or another? Or do they have just general cyanosis? Pulse, make sure all their extremities have a pulse. Pulsus paradoxus, where pulses don't match. And then skin temp, is it warm, is it cool? If you have an extremity that may be cool, that may be a sign of poor circulation. Skin temperature, which I just talked about, in the distal club, and the distal club in here at the bottom is typically a sign of a respiratory problem. Your vital signs, patients under stress can have tachycardia and hypertension just from their increased work of breathing, their anxiety, their respiratory problem. When you get to that bradycardia, hypotension, and their respiratory rate drops, that's part of that decompensation where they're starting to take it down slow. We use stuff like stethoscope, requires regular cleaning and maintenance, frequent use, and buy what's best within your budget. We use it to listen to heart and lung sounds, and you can also listen to bowel sounds. Pulse ox is a way for us to measure hemoglobin with oxygen attached. Typically, oxygen saturation of 94 is normal. Some patients with COPD may sit at a O2 sat of 89% all the time and not be on any oxygen at home. That's not unusual. Does not differentiate between oxygen or carbon monoxide. So if your patient is carbon monoxide poisoning, it's still gonna say 100%, but it's saturated with carbon monoxide, which is why your end title is so important to use to test, is it really oxygen gas exchange? Pulse ox, oxygen saturation should match the patient's heart rate. If hemoglobin level is low and your pulse ox is high, that's that oxyhemoglobin dissociation curve. Our end tidal CO2, great tool to tell you gas exchange, acidosis, are they retaining CO2, are they blowing off too much CO2? Our peak expiratory flow is the max rate at which the patient can actually expel the air out. Normal volume is 350 to 700 a minute. It varies by their age, sex, and height. Inadequate level is about 150. When we reassess the patient, we want to always look at changes in mental status, increased difficulty breathing, contact medical control. If you've tried what you've tried and you can't get anything, maybe you have to contact medical control. Document changes and your orders for medical control. Emergency care, always provide supportive care, provide oxygen, monitor your patient, and decide do you need rapid transport, do you need additional resources. Standard interventions, oxygen, keep your sats above 94 if you can help it. Do an IV in case you need to administer any medications. Psychological support, coach your patient. If you're trying to put a patient on CPAP, they may not let you if they're truly in respiratory distress. They may be anxious, so you may have to coach them into putting the mask on. So that's part of that psychological support also, which is coaching and calming your patient to reassure them you will help them. Position of comfort. Some patients will sit straight up as far as your stretcher will allow because that's the only way they can be comfortable to get air. decrease their work of breathing. Muscles work harder during respiratory distress. We use substantial energy. They require more O2 ventilation. They can't eat or drink, and they may fatigue to the point of decompensation where they just stop working as hard. We do carry medications like MAG to try to help decrease their work of breathing by causing smooth muscle dilation to help them breathe easier. It also relaxes those smooth and bronchial muscles. Help the patient sit up. Remove anything that's restricting their clothing, that's restricting them to keep them from breathing. Do not make them walk. That is going to make the hypoxia worse and the respiratory distress worse. Relieve any gastric distension they have, because the more it's distended, the more pressure and air up on the diaphragm. Do not bind their chest or have them lie on an unaffected lung if they have any lung issues. Provide supplemental O2, administer in the concentration that's most effective for the patient. Do they only need 2 liters on Mavacamla? Do they need all 15 liters via non breathing? Do they need ventilation support via BVM? Concentrations higher than 50% used only when your hypoxia does not respond to those lower concentrations. Most patients with 94% do not benefit from supplemental O2. Administering bronchodilators. Those without bronchospasms benefit only slightly. Bronchodilators are ineffective in pneumonia, pulmonary edema, and heart disease. Your bronchodilator is typically like your albuterol or your ipratropium. Some places carries Openex, things like that. This is to open up those bronchioles to allow more airflow in. Your fast-acting stimulate beta-2 receptors in the lung. Your ipratropium can be aerosol or inhaled. Sometimes prescribed with ipratropium in pre-mixed cocktail, and these help improve patients' quality of life. Patients will take these in their treatments at home. Patients will have an intermediate dose inhaler, or they may just call you and say, "I'm out, can you give me one? I'm short of breath." Your aerosol therapy, which is the T mouthpiece on top here attached to the nebulizer, they deliver a fine mist of liquid medication, and they need at least 6 liters a minute to keep those particles the right size for inhalation. It can have the mouthpiece, a face mask, or the trach collar, so you can administer one of those to a patient with a trach that is having issues with bronchospasm. Nebulizer can also be held in front of their face for blow-by, if you have to, for maybe one of those small babies. Meter dose inhalers, this is what you typically see your patients have at home. These inhalers deliver the same amount of medication as aerosol, but it's already pre-measured. It only delivers that dose when you squeeze it. And this is the spacer that helps keep it a meter dose and keeps it from patient contamination too. To avoid common errors, make sure you inhale deeply as soon as you squeeze it. Pull the medication out. Flow should be smooth and low pressure. Make sure they inhale and hold it, and then have them exhale. Make sure inhaler contains medication. Keep the spacer and canister clean, and rinse their mouth after using a corticosteroid inhaler. When they have failure of this inhaler, it's typically a user error. Patient cannot move air into lungs, may not realize your inhaler is empty. Patient may inhale at the wrong time, and you're limited by that spacer, how much you're traveling to and from. Dry powder inhalers are your fine powders. Medication can be dispersed by plastic disc. Other devices require a patient insert a capsule of powdered meds. Rarely used in EMS care and super expensive. Your leukotriene modifiers, you see a lot of patients have this with Singulair. Is there a common one that they'll have at home, a Singulair, or it's called Montelukast if you look at the generic name. This is that block bronchoconstricting chemicals, which are released by your body, those leukotrienes, and it helps with allergic reactions. Your electrolytes, IV magnesium for severe asthma, but it can cause hypotension, and that's where you see what we talk about with the magnesium causing that bronchodilation. Asthma is a reactive airway disease causing bronchoconstriction, so we dilate them to help them get more air in, along with our regular bronchodilators. Corticosteroids reduce bronchial edema. You can have adverse effects like Cushing syndrome, rapid change in BGL, and blunt the immune system, and they need to be DC'd slowly. So this is your stuff like Solu-Medrol, patients on long-term prednisone use. You'll see them have that Cushing syndrome, they have the rotund belly, they have the moon face, they have the hump back here. That's from long-term use of steroids. Steroids also increase your blood sugar, so you gotta think about that if you're gonna give it to a diabetic patient, or have any DKA, do I really need to give this to them? Which is the benefit over what weighs the benefit and the risk. So, and it helps reduce that edema, so it helps with inflammation in the lungs as well. So we give it to the IV or IM.